Just picking up where we left off last time, now we're talking about group 3 antidepressants and mood stabilizers. So we're going to start out talking about the different conditions and how these particular drugs work to treat these conditions. So just to kind of give you an idea, so these are the ones that we're going to specifically focus on today. So depression is a condition where you don't experience it for just a short term. Typically, you have to experience it for a period of time, which we'll talk about in just a minute. We'll see people with depression having, feelings of worthlessness, guilt. There might be issues with eating. Either they eat too much or eat too little, sleep too much, sleep too little. We might see some slowing of behaviors, and the person might be experiencing thoughts of suicide or harming themselves. Mania is kind of like the opposite of this, where we see sort of excessive euphoria. It's a disordered mental state, and you might think, oh, mania sounds kind of nice, but it really is a debilitating condition because some people in a manic state might, for example, not really sleep. They may go several days in a row where they're just going. They might have, they might work excessively and basically, or in a particular state that's very uncomfortable because it's like the mood is too high. Okay. And then bipolar disorder is basically a combination of both depression and mania. And so we see that if we think about the poles, right? So if you think about one pole being depression and one pole being mania, we're seeing that a person is actually cycling through and alternating between the different poles or moods. And some people cycle really fast, maybe even within days, and then other people cycle more slowly and might experience cycles within weeks or months. Now, in major depression, major depressive disorder, when you are using the DSM-5, which we've talked about before, for diagnosing conditions, or DSM-5 TR, which is text revision, what you're looking for is particular criteria. So a person needs to experience something to be diagnosed for a period of time, right? So duration, as well as meeting certain criteria. So you might get a list of, 6 or 7 items, and the person needs to have experienced at least maybe 3 to 5, depending on the diagnosis of what you're talking about, of those particular criteria in order to be kind of in the right diagnostic zone. And so with depression, for example, we tend to see patterns where people have these, like I said before, this worthlessness and guilt, eating habits, sleep issues are disrupted, that slowing of behavior, as well as potentially that person might experience thoughts of harming themselves. And, again, these are kind of some of the criteria. There's a list that you would go through and make sure that the person is actually experiencing it for a period of time. And also it is disruptive to their life. So that's one thing that these conditions, that, it has to affect some domain of your life. So perhaps you're depressed and you're not going out and meeting friends. You're not, going to work. You're not going to class. That's some domain of your life that it's impacting. It is relatively common. We see this in about 6% of the adult population who have been diagnosed. Of course, we could assume that people might experience it more frequently and not get diagnosed. We see this about twice as much in women than in men. There's a lot of theories as to why it could be hormonal. It could be, specific to brain activity and structures. It could be a social, cause as to why women might experience it more. It could be, the way that we think about men and women in terms of the social context. It could be a lot of explanations, or it's likely a combination of all of those things. There are 3 classes of antidepressants to treat depression. So the first one is the monoamine oxidase inhibitors. So the MAOIs, basically, they block the specific neurotransmitters, for example, dopamine, noradrenaline, and serotonin. They block the enzyme from breaking that neurotransmitter down, so you have more available in the synaptic cleft. So when you remove that source of removing the neurotransmitter, it will, of course, mean that more of that neurotransmitter is available in the system. So MAOIs are, you have to be careful when you use them, because obviously they're affecting, several neurotransmitters, and so the monoamine neurotransmitters. So you do have to be careful when taking them with other medications and things like that. We have the tricyclic antidepressants. We call them the first generation antidepressants. They have this 3-ring structure that blocks serotonin reuptake transport proteins. And essentially, by blocking that reuptake, they're making more serotonin available in the synaptic cleft. And then we have the second generation antidepressants, which is similar to first generation antidepressants, but these are selective. So you might have heard of the term SSRIs, or selective serotonin reuptake inhibitors. The difference between the first and second generation is that the first generation don't distinguish between the types of serotonin, whereas the second generation do. And so we also call these the atypical antidepressants. So SSRIs work by selectively blocking certain reuptake of certain serotonin receptors, allowing for more serotonin to be available in the cleft. And so that presynaptic terminal has more serotonin available. So just kind of looking at this in terms of agonists. So here the MAOIs, they don't allow for the breakdown of serotonin. And so it allows for more serotonin to basically be processed, right? So that allows more serotonin to be released, which eventually will mean more serotonin in the cleft. More specifically, the selective serotonin reuptake inhibitors, SSRIs, these are essentially blocking the transporter protein here that means that more specifically that serotonin will be available in the cleft. So, looking at these different actions, so they both serve as serotonin agonists. This MAOIs are specific to blocking the breakdown, meaning that there's going to be more available for release and eventually be able to be in the cleft. But this is more directly making serotonin stay longer in the cleft, if that makes sense. I'd said it, I think, in a confusing way. So MAOIs, more available to release, and SSRIs mean that more serotonin is available in the cleft, stays there longer so that they can bind to receptors. So the thinking about how we are trying to explain what depression is and what's causing it. So just like we have the dopamine hypothesis and glutamate hypothesis for schizophrenia, we have the monoamine hypothesis for depression. And that's basically that we just do not have a sufficient amount of activity of monoamines at the synapses. And the reason why we have that, one, is that MAOIs work to allow for more monoamines to be available, and for some people that does reduce their symptoms of depression. Another example is reserpine, which reduces norepinephrine and serotonin, and this medication causes profound depression. So this medication is used to treat high blood pressure, but it works so efficiently with reducing norepinephrine and serotonin in that it causes depression. So people who are depressed take MAOIs, and that reduces their symptoms. So that's evidence. People taking reserpine, which is reducing these monoamine neurotransmitters and causing depression. That gives us 2 pieces of evidence for the monoamine hypothesis. Now, the problem is, though, is that not everybody, so evidence against the monoamine hypothesis is that not everybody responds to monoamine treatments, okay? And I've got a couple other pieces of evidence as well in the next one. But so one, if you give a person a placebo and an antidepressant, they're equally effective. The only exception to this is people who are severely depressed, okay? So if we're talking about this range right here, severely depressed, you're going to see that the drug is much more effective than the placebo at reducing the symptoms of depression or severity of depression, or you see a much better improvement from placebo to treatment. But here, if you look at this kind of range of less severely depressed, it's not impressive, right? So placebo works relatively well. So what is a placebo, right? Placebo is basically, like, we call it like a sugar pill. Basically, the person thinks they're taking a medication, but there's actually no active medication working to treat their condition. So if you give somebody medication and say, you're going to feel better, your depression is going to be relieved, and they take that medication and it works, then that's what we call the placebo effect. Well, it turns out that we do see the placebo effect with depression in in a lot of cases of people with depression. And so it's really confusing because we know that there's atypical neurotransmitter activity here. What is explaining? We don't understand exactly why. In some cases, some medication works, and then sometimes placebos work. And it's not as effective as we would like it, especially if we're trying to just explain and provide evidence for this monoamine hypothesis. Now, another issue, similar to how we look at schizophrenia and treatment of that, you can take an antidepressant, they're gonna impact that synapse immediately, but the actions that we see, the longer term effects take weeks to develop. You need to be on an antidepressant for weeks before, 6 to 8 weeks before you're really going to see any kind of reduction in your depressive symptoms. So again, if you're seeing activation or synapse activity immediately, then why does it take so long for the medication to basically kick in and reduce the symptoms? And we don't have an answer to that. Now, one interesting idea is that Prozac, which is an SSRI, it enhances neurogenesis in the hippocampus, and maybe it's just that it takes time for that neurogenesis to happen, and that is part of the process of, reducing the symptoms. Is that part of the therapeutic effect? We don't know, okay? Also knowing that about 20% of people of patients with depression, they fail to respond to any antidepressants. And so that suggests that depression probably has a lot of different causes, and we haven't quite centered in on exactly what that is. Now, Dumont in 2004 had a really interesting paper talking about what are some other causes for depression. So one suggestion was that depression may involve low levels of neurotrophic factors. We've talked about some of these. One of these that we talked about is brain-derived neurotrophic factor, and it could be that BDNF is downregulated, mostly by stress, right? And that it could be upregulated by antidepressant medications, okay? So if that's the case, where we see downregulation by stress, that explains all the studies that we see that talk about how stress can directly impact our mood and how we feel and our emotions and our and potentially exacerbate depression. And we know that stress causes cortisol to increase, and that causes us to feel like we're in a constant state of fight or flight. And so it could be that we see that these, that this sort of upregulation of BDNF to counter the stress cause downregulation, perhaps that is what's impacting the brain. We also see that those antidepressant medications, it may increase BDNF by altering C-AMP transduction. Now, we haven't really gotten much into that, but thinking about the process of how neurons function and how they need specific nutrients to be able to live and do their job. This is a really good explanation, but again, we just don't have as much evidence to 100% identify that this is what's going on. Now, if we look at other pieces of evidence that explains why we experience depression and why, in some cases, these certain medications do and don't work, we know that people who have high levels of glucocorticoids struggle with depression. And so Cushing's syndrome is an example of this, where it's caused by a tumor in the brain, and usually it's around the pituitary gland. And so a person with Cushing's syndrome has a really, really high level of stress hormones. They have high levels of cortisol. They have high levels of circulating adrenal glucocorticoids. And it's caused by basically a tumor that's sending out way too many signals and way overactivating this system. And so it could be that, looking at this particular condition, this may be a piece of evidence that really says, okay, people who are really stressed have high levels of glucocorticoids, have high levels of cortisol, and this can be something that's causing that. So we see this in this particular syndrome as well, and it's resolved by removing the tumor, and the tumor that's causing all this overactivation of cortisol. Now, if you look at, and we're not going to go too much into this, I'm not going to spend too much time into this, it's all this giant cycle, right? It's this feedback loop of, okay, we get stress in, and then it's going to impact us through a particular circuit called the HPA axis. This is the hypothalamic pituitary adrenal circuit, where your hypothalamus, your pituitary gland, and your adrenal glands are all working to essentially process this stress and then just continue to release different hormones like cortisol, for example, secrete these hormones to combat this stress response that's coming in. Because normally if you're in fight or flight, the stress response is good, right? You say, okay, super high levels of cortisol, get me through this moment, and then they should fall back down to normal values again. Well, in people who are chronically stressed, they don't get that back to normal level. They're in a constant state of stress. And so this oversecretion of cortisol could be causing the depression, because it essentially runs this loop basically over and over and over again, and it doesn't get a reprieve. So we also know that the amygdala is involved. The amygdala is really important for our emotional response. It's tied to our fear response, whether directly or indirectly has an impact on our mood. And we also know that because of these different feedback loops and these different information, moving to the frontal cortex, for example, we see the potential for decreased executive function. And so that is going to then be related to, again, activity in the amygdala. So we see that the amygdala activity is inversely related to the activity that we see in the dorsolateral prefrontal cortex. And so essentially, you see that a person is experiencing issues with control and with emotion, and those kind of moving back and forth and causing a never-ending cycle. Now, when you have a person who is experiencing depression, okay, think of it like almost like a treadmill where there's a cycle, right? So we have these negative thoughts, right? These negative thoughts of, why am I here? I'm worthless. I'm helpless. Why bother trying? I have no motivation, right? That's going to lead you to have low mood. You might feel guilty. You're going to have those feelings of inadequacy and worthlessness, which are, feeding from those negative thoughts. So that's going to cause you to have a low mood, which will then change your behavior and reduce your behavior. You might become socially withdrawn, for example, which then leads back into those negative thoughts. No motivation. Why bother trying, right? Now that's, decreasing my mood. I feel guilty and worthless, which is going to change your behavior, and then so forth and so on. Now, CBT, or cognitive behavioral therapy, is a way to change your thought process. And it could do it at any of these points, right? So it can change your thoughts, it can change your mood, behaviors, whatever it might be, and trying to essentially break the cycle. It's a really, really great program. The one downside that for a lot of people is that it does take time and effort. This is something that you do have to be, you have to go to regularly. It's probably going to be something that you're going to have to do for the rest of your life, and you have to keep up with it as work. So what some people might do is they might start out with an antidepressant coupled with something like CBT, and then try to sort of wean themselves off. Now, there are people who they don't respond to medication, and then those who take medication but understand that there is, of course, a risk when it comes to taking SSRIs. So one major risk is that in young adults or teenagers, there's a really high risk of suicide and thoughts of harming themselves. And so we want to be really careful about how certain medications are diagnosed for certain stages of development, because you don't want to necessarily cause even more problems or have greater side effects. We also see that there's synergy with other drugs that might impact serotonin. So we can actually see serotonin syndrome where there's just too much serotonin in the system, especially if you're taking like ecstasy, or a drug that impacts serotonin. So some symptoms of serotonin syndrome are things like confusion, spasms, fever, and death. It can severely dehydrate a person, and somebody might very quickly have these symptoms and essentially die in a very short time span. So it's really important that we consider that there are side effects to these drugs. So in response to that, some people choose other non-SSRI treatments. So for example, ketamine and psilocybin have been used. So this is like mushrooms, and this is called Special K. There's been some really interesting ketamine trials that have been going on that have been very successful in reducing depression, and especially in cases of like PTSD, things like that, have been very helpful. CBT is a very, very helpful treatment. ECT, or electroconvulsive therapy, ECT is not something that you would immediately jump to. This is something that does have side effects. Some people do experience, a lot of times people experience amnesia after doing ECT, and they'll only do a few treatments. So it's essentially shocking the brain. It's like electric shock. And what that does is it does help to activate certain systems. It does wear off. And so you do want to be careful about how many times you do it, but it's very, very controlled, and it's really only used for like the more severe cases. We also see deep brain stimulation, which is essentially an implant that's put in. So it is, something that is a surgery, again, used for the more severe forms of depression. You also see TMS, transmagnetic stimulation, or TDCS, which is transcranial direct current stimulation, which is a little bit less invasive, I should say. Basically, a wand that gets put over the head and stimulates different areas of the brain. So there have been some really successful treatments of using TMS and TDCS for depression. Some clinical trials, especially at MUSC in Charleston, have been very helpful in treating people with depression and other conditions. It's mostly used for depression and like bipolar disorder. So what do we see happening in a person who has depression? So we see their dorsolateral prefrontal cortex. We see issues here where there's decreased activation. And so when you have less activation in the dorsolateral prefrontal cortex, you see people tend to have issues with cognitive flexibility. They have a hard time switching gears. So if they're talking about something or thinking about something, they can't handle something else coming at them. They're not able to multitask. They might really only be able to kind of think of one thing at a time. You might also see apathy. They don't really care about much. You might see irritability, as well as reduced spontaneity. They're just not really excited about life and not as spontaneous. The decreased activation that you see in the dorsolateral prefrontal cortex is linked to illness severity, as well as cognitive disturbance. And so obviously the more severe the case, the more severe that you see the disturbance. The OFC, or the orbitofrontal cortex, we do see more activation in this area, and we see that the orbitofrontal cortex's job is to appropriately respond to reward. And so in a person with depression, we see that their OFC is not functioning typically, and they have that reduced ability to respond properly to reward. They may experience dysphoria or anhedonia, which is just essentially they're not getting any happiness from life. They're not experiencing, it's just like very, very low mood, and they're not happy about living. And so we can see that the OFC actually does normalize in people who respond positively to treatment. So we can see this as being a reversible effect in a person with depression. Now the ACC, which is the anterior cingulate cortex, we do see a reduction of the ACC in people with depression. We also see that people with depression tend to have an impaired response in terms of inhibition, response inhibition. They also have apathy, so they're apathetic. They don't really care too much about much. They just, are here. And we also see that how much we see the activity reduced is related to the therapeutic response. So if you see a higher activity, you tend to see that person will respond a little bit better to medication. So it can be used as a little bit of a predictor, but it's not something that is necessarily used like clinically or by a physician. This is something that we see more so in experimental studies. I'm going to go through the group 3 only because we only have a couple of slides for this one, and then I'll do the last video will be, the next video will be opioids. So group 3, these are mood stabilizers. So we talked about depression, and we talked about mania. And so bipolar disorder is this kind of combination of depression and mania. So this group 3 mood stabilizers will help kind of describe how we treat people with kind of both sides of mania and depression. And you can see here that, we do see different kinds of activation when a person is in a depressive state versus when a person's in a manic state. So you can actually, or vice versa, I should say. So this is the manic state and this is the depressive state. So you do see a higher activation in some areas where you see more blunted activation during the depressive state. This is a really very visible, measurable effect of this particular condition. So bipolar disorder, we see this cycling through, euphoric mood, expansive mood, and depression. And again, the cycling varies. It could be that a person experiences, at least 4 cycles. In a year, somebody might cycle more than once in a day or several times in a day. Typically, you might see people cycling throughout weeks or months. But again, the rate of cycling is sort of individual based on the person. Cyclothymia is a milder form of bipolar, and there's 2 versions of bipolar 1, bipolar 2, with one being more severe. But we also have this cyclothymia, which is basically a kind of mild form of bipolar. And they cycle through a dysthymia, which is like depression. It's a milder form of depression. It's higher than apathetic, but it's or low mood, I should say, rather than apathetic. But here we see kind of just this mild depression and then increased energy, which is hypomania. So we see this basically version of bipolar that's sort of watered down. And so some people do struggle because they need a diagnosis of cyclothymia, but it's not severe enough to be considered bipolar disorder. And so there may be some people who feel like it takes longer for them to get diagnosed properly because their condition is a milder form. Now, lithium has been used for many years to treat bipolar disorder, and historically it was used in the 1870s. And even used prior to the 1870s for gout. And so gout is this buildup of acid in the joints, and so it's a very painful condition, and so it was used previously for gout. But even as far back as the 1870s, it was being used to treat mania. Like you see cocaine and Coca-Cola back in the day, it actually used to be in 7-Up. And so it was available. And so it's been used for quite a while. And so there are widespread actions in the brain that lithium is essentially impacting. It interferes or interacts with the circadian clock. It does have an impact on circadian rhythm, and it boosts that BDNF activity. And remember, we talked about that before as potentially being an issue with depression. And so one way that lithium works is that essentially it mutes one pole. When you're able to, for example, mute depression, if you're not going to have a depressive episode, then you may not experience a manic episode, because typically a person experiences a depressive episode that's followed by a manic episode. So if you can kind of cut one out, then the idea is that you cut the subsequent episode out. Now, when it comes to looking at the length of time, so typically people experience a much longer depressive episode than they do with mania. So they may experience several weeks of depression and maybe a day of mania, a manic episode. And so it is a very sort of unfair condition. But again, that varies based on person to person. But the idea is that lithium can mute the intensity of one of the poles, therefore stopping the cycle of the person experiencing the flip back and forth. Now, many of the mood stabilizers are actually used for as anticonvulsants. So for people who have seizures, for example, and seizure disorder, they may be taking anticonvulsants. But some, not only do we see lithium being used, but we also see that some antipsychotics can have mood stabilizing effects as well. But what we see is that the mood stabilizers tend to treat the manic and the cycling of the condition, but not necessarily, it doesn't treat the depression part of it. So again, depending on what the severity is and what the person is experiencing will depend on what kind of medication it falls down. Now, if we look at what is causing bipolar disorder, we still don't really understand what's going on. We know that lithium could increase serotonin release, so maybe bipolar disorder is something to do with an imbalance of serotonin. Valproate stimulates GABA activity, so maybe there's some inhibition on some overactive areas. Again, the mechanism behind bipolar disorder isn't quite as well understood, and so we're not as sure why some medications work in some ways and then some don't work at all. So the next thing that we're going to talk about are opioids, and so just hop on over to that video and then you will learn some